All right. Good morning or afternoon for those of you joining us from outside the United States. It's my pleasure to welcome you to Ethics Grand Rounds. My name is Sandra Lee, and I'm Professor of Medical Humanities and Ethics and Chief of the Division of Ethics in the Vagelos College of Physicians and Surgeons at Columbia. For those of you joining us for the first time, Ethics Grand Rounds is a series organized by the Division of Ethics that aims to bring our community across schools and campuses at Columbia and beyond for meaningful engagement with the most pressing ethical challenges facing our society's pursuit of health and well-being. The goal of our Division of Ethics is to integrate humanistic perspectives and ethical reasoning toward alleviating human suffering and promoting justice and equity in scientific practice and healthcare. Our multidisciplinary faculty and staff lead and support normative, conceptual, and empirical research and scholarship on ethical questions that relate to biomedical sciences and healthcare, and to cultivate multidisciplinary collaboration that fosters innovative, high-impact, data-driven ethical policy and practice that furthers equity in science and clinical care. The theme of our Ethics Grand Rounds this year is race in biomedicine. The global pandemic has made exceedingly clear how deeply rooted inequities result in the most disadvantaged communities disproportionately being burdened by illness and suffering. The pandemic put in stark relief the lethality of an ongoing legacy of structural racism. In the US, murderous violence against people of color has become seemingly ubiquitous, a feature of American life, most recently in the tragic shooting deaths of 10 Black Americans in Buffalo by a young man who released a manifesto decrying the replacement of white America by immigrants and people of color and asserting white supremacy through claims of genetic racial superiority shortly before committing his acts of terrorism. In focusing our race and biomedicine theme in Ethics Grand Rounds this year, we gather to reflect on the production and impact of racism in our society in this moment, and to consider how we as scholars, clinicians, scientists, educators, students, and more will respond in our own work. Through this series, we aim to catalyze discussion on how to interrogate structures and deeply held beliefs and practices that perpetuate racial inequity, and to identify ways to intervene. Addressing race, racism, bias, and inequity are fundamental ethical and moral responsibilities for a science and a profession aimed at alleviating human suffering. We have an opportunity and an obligation to ask how we will each take up this challenge and create meaningful and impactful change. In keeping with this focus for this year's Ethics Grand Rounds, we are focused on policy and education, and we have a wonderful session today that will address anti-racism in medical education and what this requires. But before I turn to our Grand Round speaker, I'd like to first acknowledge and thank our Ethics Grand Rounds Planning Committee. This group includes faculty from both uptown and downtown campuses at Columbia and NYP. I also want to recognize our program staff in the Division of Ethics. Angelica Johnson, Dunya Alami Nassif, and Rachel Yarmolinsky have provided crucial support in implementing this program today. Now, it is my great pleasure to introduce our speaker, Dr. Clarence Braddock. Dr. Braddock is Executive Vice Dean and Vice Dean for Education in the David Geffen School of Medicine at the University of California, Los Angeles. He has held the Maxine and Eugene Rosenfeld Chair in Medical Education since 2015. And in these roles, he helps lead the medical school in its mission of research, education, patient care, and community engagement. He also oversees all aspects of education, including undergraduate, graduate, and postgraduate programs. And he launched and leads the UCLA Anti-Racism Roadmap, an initiative to transform institutional culture and practice. Dr. Braddock's research is focused on bioethics, shared decision-making, and patient-physician communication, having developed a widely used framework for teaching and for evaluation of the quality of shared decision-making in practice. Dr. Braddock and I share our alma mater, having earned his undergraduate degree at Stanford University, and then going on to receive his medical degree at the University of Chicago. He completed internal medicine residency training in the US Navy and received his master's in public health degree in healthcare ethics from the University of Washington. I first met Dr. Braddock many years ago when he was on faculty at Stanford, and had the pleasure of working with him more recently as co-chairs of the Association of Bioethics Program Directors Presidential Task Force on Racial Equity, Diversity, and Inclusion. He is exactly the voice we need at this time, and I'm very excited for his talk, which is entitled Anti-Racism in Medical Education, Addressing Barriers to Change. Following Dr. Braddock's presentation, we are fortunate to have our own Dr. Monica Lypson to give her remarks. Dr. Lypson is the Vice Dean for Education in Vagelos College of Physicians and Surgeons here at Columbia. She is also the Rolf H. Scholdager Professor of Medicine. She graduated from Case Western Reserve University School of Medicine and completed her internal medicine residency at Brigham and Women's Hospital, excuse me. Her research interests include resident assessment, historical and contemporary trends in medical education, academic leadership, and the underrepresentation of minorities in academic medicine. So as you can see, this is truly an extraordinary opportunity to hear from these thought leaders today. I know we will learn a great deal from them. Before we turn to them, just a few logistical details. If you wish to use closed captioning, please turn on the CC button at the bottom of your screen. We will have ample time for your questions, and I encourage you to submit your questions using the Q&A function also at the bottom of your screen. You can register your enthusiasm for a question and elevate it up the list by using the upvote button in the Q&A box. And there is the chat box available for further engagement, and we will be posting links and resources referenced in today's discussion there as well. If you have any questions at any point, please email us at mhe_ethics@cumc.columbia.edu at any time. All right, so without further ado, it is my utmost pleasure to hand it over to you, Clarence.
Thanks so much, Sandra, for that really wonderful introduction. I'm just going to share my screen here and then begin. Let's see here. Okay. So it's really a wonderful honor to be invited to give this grand rounds. I was listening to Dr. Lee's introduction about the purpose of the ethics program there to interrogate existing practices. That's really the spirit of the remarks I'll give this morning, for us to think about the training of physicians and how, as we find ourselves in this time, trying to make a real meaningful commitment to anti-racism in medicine, how we're doing and how we can do better. So in my remarks, I'll address really these three questions. First, a little bit of an overview of existing trends, what we're seeing around the country in schools like ours, your program there at Columbia, and of course ours at UCLA. And then I'll spend most of my remarks talking about 5 barriers that are really things that we need to contend with, to address, to really internalize and reflect on if we are going to bring about real, lasting, significant change. The third question is, what do we need to do to surmount these barriers? And although I'm not going to address those formally, I hope as I'm talking, some of those approaches will occur to you as you listen, and certainly in the Q&A, I hope that we can talk about the concrete things that we can do to begin to address these barriers. So first, as Dr. Lee said, I'm proud to have launched at the David Geffen School of Medicine, the Anti-Racism Roadmap. I'm not going to talk about it in great detail, but I think in the work, one of the things, many things we've realized is the enormity of what is anti-racism and how to really meaningfully address an anti-racist agenda in training physicians, let alone in our health system and our broader work. Now, we're not alone. There are many schools across the country. This is just a partial list. I just listed the first 10 I found in a Google search a couple of weeks ago. And Of course, your institution and ours are on this list, but many others that you can see. And this is, again, just a partial list. There's actually, I want to call out, in particular, Mount Sinai Icahn School of Medicine that has launched something that is called the Anti-Racist Transformation in Medical Education, of which both our two schools are a part. It's a consortium of schools really trying to work together to create the processes and actions necessary to have a truly anti-racist transformation. So these are important to recognize, and it goes without saying, but I'll say it, that in large part, all of these efforts, literally all of these efforts of anti-racist transformation go back to the murder of George Floyd and the reckoning that has been happening throughout the nation and certainly throughout medicine and medical education. Lots to be said about why it took that, but I'll leave that for the Q&A or for commentary. But it's good that we are having these efforts, but the efforts themselves will be insufficient unless we address some of the big barriers and big issues that are at the root. So when I say anti-racist curriculum, obviously every school is approaching it a little bit differently. This is, again, a partial list of the kinds of things. When medical schools say we're going to have an anti-racism or anti-racist curriculum, some places, I think importantly, are addressing the history of racism in medicine, and particularly in the United States. And some of the things that leap to mind there are, of course, the legacy of the U.S. Preventive Services syphilis study at Tuskegee, the experimentation on Black women in the field of obstetrics and gynecology. The list goes on, but also talks about the history of racism, not just in medicine, but in the United States. And I'll reference some of the important work that's out there for your consideration in that. A lot of medical schools focus on skills, that is, the skills built on a foundation of understanding concepts like implicit bias and stereotype threat, understanding concepts like being an ally, sort of the bystander, upstander training, cultural humility, trying to move away from the notions of cultural competence. There's a lot of skill building that happens in medical schools, and it's important. A third area, again, this is just a partial list, is structural competencies. I'll talk about that more in just a moment. But the notion that understanding the things that influence health and understanding the role of racism, social factors, et cetera, in shaping health, and importantly, communicating the message that as physicians, we have a responsibility to not just provide outstanding patient-centered, culturally humble care to patients, we also have a responsibility to be actively engaged in addressing the structural factors that influence health. Just to give you a flavor, this is actually data from the Association of American Colleges website, and it just shows the number of medical schools, about 155 schools in this database that have some required or optional curricula around, they call structural determinants. For the sake of this discussion, it's really this issue of structural competency. So it's a good number, but it's not all schools. And again, what we don't know as we dig into this is the depth and impact and substance of that curriculum. So that's something we need to continue to look at. Okay, with that backdrop, I'm going to talk about barriers. I'm going to talk about 5 areas that I think really require substantial attention and reflection. The first is the continued use of race as a biologic construct in medicine and other historical fallacies. I'll focus primarily on the use of race as a biologic construct. One second, why is that? Okay. The second is thinking beyond our traditional focus on equity, diversity, inclusion, which is of course important, but moving beyond that to this issue of what anti-racism really means. And I'll talk about that particularly in like the myth of colorblindness. The third will be intersectionality, a term that hopefully most of you are familiar with, but actually presents both an important concept, but if improperly framed or not understood properly, can actually be a barrier to what by being what some have called the oppression Olympics. I'll talk about the contrast between being an ally and being a savior. This is particularly directed at our white colleagues who it's important to reflect on that critical difference. And the fifth will be the need to differentiate mentorship from sponsorship. And this is particularly thinking about physicians in training of color, women physicians who are trying to surmount traditional barriers to success and fulfillment in a career. And this concept is going to be very important. Okay, so let's first talk about race, the biologic construct. And if you're not sure that race is still treated by physicians as a biologic factor that predicts disease or response to disease treatment, you need to look no further than picking up any biomedical journal within the last week and looking for this table. So I actually literally picked up the JAMA last week and flipped through articles of clinical trials. And this is a clinical trial of self-monitoring of blood pressure and how that during high-risk pregnancy and how that impacted outcomes. Self-monitoring versus usual care. And I draw your attention to, this is a typical table 1 in every clinical trial, which gives the characteristics of the study population and the control group. And it almost always includes race. Now, why does it include race? Well, some might say, well, it's important to make sure that in the accrual for a clinical trial, you have a broadly representative patient population in both control and the experimental group. Very valid point. But it would also suggest is that we believe, and then you start looking at results, the results will be very often broken down into how the intervention worked for Black patients and how it worked for white patients. And while the former reason for including race might be defensible, the latter is not, because race is not a biologic construct. Race is not a factor that predicts disease. Racism is a factor, but it's not a biologic factor, it's a social factor. And that brings me to, again, many of you have probably seen diagrams like this. This is a very widely accepted, certainly in public health, conceptual model of the factors that influence health. And importantly, for the physicians in the audience, we must recognize that what we do in healthcare, even if we're doing our best with ideal access and ideal quality and good decision-making, healthcare, the delivery of healthcare only influences health only about 20%. It's actually very small. The vast majority of health is influenced by things other than healthcare. That's a humbling thing for physicians to know, but it's also important because if we want to, as physicians, advance health, we must not only know about these factors, we must find ways to address them. And in this model, 40% of health is determined by so-called social factors. Now, this is an older slide, but if you look at more modern versions of this model, racism would be in that category. Physical environment accounts for about 10%. Again, these are not exact numbers, but roughly speaking, and health behaviors account for about 30%. Again, health behaviors and physical environment are not isolated factors in and of themselves because they're heavily intertwined with racism, with marginalization, with other factors that you think about the promotion of menthol cigarettes in the Black community, right? So menthol cigarettes, if tobacco use is a health behavior, it's not separable from racism, right? So we have to transcend the youth as physicians thinking about race as a biologic construct. And I say that to the medical students that may be listening. Ask yourself if when last time in a lecture or on the wards or in the clinic, someone was talking about, well, we don't use this medication in Black patients, or this disease is more prevalent in Black patients. You must question that because it's a continuation of this false use of race as a biologic construct. The second challenge and barrier is moving beyond EDI to really understand what anti-racism means and recognizing the myth of colorblindness. So as I think back over my career in terms of this kind of work, when I was in medical school, we had an Office of Minority Affairs. Basically, we got some Black students, let's have an office so they can get some help making through medical school. Then the notion that became replaced by a real emphasis on diversity, programs to say we really need to bring into medicine more diverse medical student bodies so we can diversify the profession. Well, we started to do that, but quickly realized that diversity itself is insufficient. We have to take active steps to develop a climate of inclusion. So the Black, brown, Asian, women students in times where women were less present in medicine than they are today, there was a need to take active steps to create a climate of inclusion. That also proved to be insufficient. It was replaced by the notion of equity and diversity and inclusion. It's not enough to have diversity and inclusion. You have to take active steps to promote equity. Then we added the notion of justice. That's actually the title of our office at UCLA. The notion that equity is one concept, but justice is a related but very separate concept. And finally, we find ourselves talking about anti-racism. There are many books and writing about this, certainly in the last 2 years, if not longer. And I put this slide up mostly to give you a few titles to grab onto. We at UCLA have a common book program in the medical school. And this year, our common book was Cast by Isabel Wilkerson. I highly recommend it. The author tries to look at racism in America through the lens of really historical comparisons to Nazi Germany and anti-Semitism and in India, the caste system, and the parallels are chilling. I'll just leave it at that, but I highly recommend it. And most of these other books you've probably seen, but certainly anti-racism. If you find yourself wondering what is anti-racism, what does it mean? Here's some things that I'd highly recommend you to read. And in particular, I'd point to, if you're white, the book White Fragility, written by a white author about why it's so hard for white people to talk about racism, would be a great place to start. As I think about anti-racism, I thought I'd use a case briefly. So this is a hypothetical corporate attorney by the name of Angela. Angela is pregnant, as you can see, and in fact, she and her spouse have just purchased a new house. That's why there's nothing on the wall, just a brand new, freshly painted fireplace mantle. But she's pregnant, and so I want to have you think about what might be going through the mind of the obstetrician seeing Angela for her first prenatal visit. One thing the obstetrician might think, I hope wouldn't, but might, is if that physician were racist. And that physician might fall into negative stereotypes about Angela because she's Black. She's probably going to be angry. She's probably going to be non-compliant. I wish I didn't have to take care of her. We would all point to that as completely inconsistent with anything resembling the values of medicine, let alone the values that this country is founded upon. But I put that out as sort of one end of the spectrum. The non-racist physician might say, well, I don't see color. I'm going to put aside any biases I have and treat Angela exactly as I would any of my white patients. Now, if you find yourself thinking, that sounds pretty good, I'm going to convince you that it's not sufficient. And that comes to the myth of color blindness. This notion of color blindness in the United States goes back a long way, but certainly one pivotal moment was the very well-known I Have a Dream speech by Reverend Martin Luther King in 1963. And you see the quote there where he dreams about his children one day living in a country where they're not judged by the color of their skin, but by the content of their character. Was Dr. King thinking about color blindness? Perhaps, but certainly he may have been thinking that color blindness would be better than the overt racism and segregation that he experienced in his life and saw in the nation at that time. So let's talk about this, unpack this concept, I don't see color. First of all, there's a huge flaw in that and not acknowledging the real experience of being Black. And I'm gonna give you two examples. This is a little diagram that shows a very common phenomenon. Two people walking down the sidewalk in the street, in the town, a Black man and a white man. The white man sees the Black man approaching. What does he do? He crosses the street. Why does he cross the street? He may not even be conscious that he's crossing the street, but he crosses it because he has some racist thought or aversive thought that he wants to avert an interaction with the Black man. Now, what does the Black man experience? What the Black man experiences is he sees the white man crossing the street. He experiences yet another example of someone white who is making a judgment about him because he's Black. Now, I've had this experience in my own life. I'm sure many of you have as well, if you're Black or brown or whatever form of identity. But this is, if the notion of saying I don't see color flies in the face of the reality of this kind of experience. Here's another example. This young Black woman is holding up a sign that says, You don't sound Black, you sound educated. This one caught my eye because I've heard this myself many times in my life. And it's offensive because it's what the person is saying to me is, I don't expect a person who's Black to sound educated. There's a huge growing body of social science and neuroscience. I can't, in the scope of these remarks, say enough about it, but just will point out some of the concepts. We are familiar with the implicit association test around implicit bias. There's a huge area of so-called social identity theories that talk about concepts like in-group favoritism, that we have a conscious and neurochemically bound way in which we prefer individuals who are in our in-group, who are like us, and we therefore are more distant from those in the out-group. Here's a brief snippet on this. This comes from a study of where the subjects were shown short videos about inspirational figures. And on the left side, the inspirational figures were from their in-group. So if the experimental subject were white, it was a white inspirational figure. And what you see is lighting up in certain parts of the brain that correlate with affection, association, kinship. They're shown the same exact vignette of an inspirational figure, but the figure is from the out group, Black, brown, a woman, what have you, and that those areas don't light up. My point here is that in-group favoritism is an important concept that we're not addressing in medical education, and it's telling us that this is hardwired into us, and without active attention and intention will continue to be a barrier. There's a huge area of research on this, the impact of racism on health. This goes back to what I was saying about structural competency. As physicians, we need to understand not just the history of racism, but the evidence of how racism influenced health. So going back to Angela, in brief, there's a huge body of research around racial differences in outcomes, in maternal outcomes. Low birth weight infants, perinatal mortality of the infant and or the mother, huge differences. This shows the magnitude of those differences, but what's important are not just the figures, but the fact that where you see American Indian, Alaska Native women and Black women, in many of these studies, those differences exist even when you control for income, education, overall health status. Why? I don't see color. Why is that problematic? Because it fails to acknowledge or dismisses the impact of racism on my lived experience. So if you tell me you don't see color, you're dismissing that experience. It also fails to recognize the impact of racism on my health status. And it ignores the growing body of evidence in social sciences and neuroscience that racism is hardwired into this country. Back to Angela. So hopefully she doesn't experience this thought bubble from her obstetrician. This one wouldn't be as bad, but it's still insufficient. And this is just kind of made up, but a better, more anti-racist view would be if the obstetrician thought, Angela's a Black woman. I wonder if I bet she's experienced racism. And I know from the data that this will influence her health outcomes. What can I do as her obstetrician to try to mitigate or prevent that? That is anti-racism. And that is different from being not racist. Shameless self-promotion. I do have a piece about this that I go into more depth in an issue of the American Journal of Bioethics last year. So there, if you want to read further on it. Third is concept of intersectionality versus the oppression Olympics. So on the left-hand side, your intersectionality, you know what that is, but just in case, basically the idea of overlapping identities of that one might have, perhaps numerous of them, and each of them is connected to a system of oppression, domination, or discrimination. This is a very important issue for us to reckon with and work on. However, it's also potentially misused. And this piece from Copeland is a nice piece that I came across from last year. Systems of oppression and its participants succeed when we fight against one another. We're doing the job of oppression for them. And I will take that one step further. Intersectionality can be misused by the dominant caste to split the oppressed castes. So that, what does this look like? You're in a conference talking about developing a mentoring program for Black faculty. And a white colleague raises their hand and says, well, you know, this is great, but we need to do more for women. The answer is yes, we need to do more for women. But in that act, what looks like intersectionality is purposely slowing down progress on the front for one oppressed group because of a purported worry about another oppressed group. Now, if it sounds like a cynical viewpoint, I'll take that criticism, but I'd invite you to think about this. There's a lot of chatter about this in minority communities and marginalized and minoritized communities, but it's something we have to grapple with, because an overemphasis on intersectionality or using intersectionality as an excuse for progress is a problem. Fourth, the ally versus the savior. And so in this one, what I would say is, this is a clip from a very well-known movie about, now I'm blocking on the name of the movie. It's one of those things that have, you know what movie I mean. It's Atticus Finch is representing Tom Robinson. Tom is a Black man who was accused of raping a white woman in a southern town. And in the book, Atticus Finch, a young attorney, decides to take on this case to kind of burnish his reputation. And he does a fantastic job. I won't tell you what happens in the end, but is Atticus Finch an ally to Tom Robinson or a savior? An ally or a savior? He's doing something on Tom Robinson's behalf, but he's doing it from a position of power and influence. And when he's done, Tom Robinson is in no better position vis-a-vis being oppressed and dominated than he was when he began. To Kill a Mockingbird. I don't know how I could forget that, but you know, under the pressure of the bright lights, sometimes your mind goes a little blank. So in To Kill a Mockingbird, Atticus Finch is a savior, is a white savior. And I leave that concept with you because as we think about how this, again, particularly for my white colleagues who are listening, as you think about how you can really be an ally to your colleagues, to be cautious about being a savior, you should act in a way that empowers and gives agency to your colleague who's oppressed or minoritized, to not just take care of them or save them. Lastly, mentorship versus sponsorship. And there's a great quote from a piece in Medium. It's an online journal, business journal last year. It says, marginalized groups shouldn't have to make the trade-off between having safe spaces with mentors versus having real advocates in the workplace. And this chart shows the contrast between mentorship and sponsorship. A mentor helps and gives advice. A sponsor helps the protege to drive their vision. Encouraging achievement versus acting and doing active things to involve the protege in activities. And you can read the rest. The main point is that it's very common for a young white male executive in the workplace to have a senior colleague take them under their wing, introduce them to the right people, invite them to the right parties, give them the premium cases. That is sponsorship. For women and for people of color, certainly in my case, I never had a sponsor. I never had someone who actually took active steps to try to advance my career. Plenty of folks who are very encouraging, but this, as we think about bringing people of color into medicine and creating a place in which their advancement and achievement can be actualized, those structures must move from mentorship to sponsorship. So I thank you for listening to these remarks. I hope that you find them interesting and helpful and stimulating discussion. I've reviewed the trends that you see, and they're, I only scratched the surface, but these are 5 areas. And why did I choose 5? Well, I had to stop somewhere. There's a lot more, but these 5 are particularly meaty from my viewpoint. And I hope it's also stimulated in you some thoughts about how we might begin to address these barriers and others. So thank you very much for your kind attention.
Thank you so much, Dr. Braddock. There is so much to discuss from what you've presented. And before we turn to Vice Dean Lypson, I just want to take a moment to remind folks to use the Q&A box to submit your questions for both Doctors Braddock and Lypson. We have a very large audience with us today, and there is tremendous collective wisdom in this room. So I want to encourage each of you to engage our speakers today. And also, I wanted to make sure you all know that the scholarship and resources that have appeared in the chat, there's a lot of richness there. We will make that available to everyone after the event as well. So I am absolutely delighted to now turn the floor to Vice Dean Lypson for her remarks. Thank you.
So I was so excited when the department asked me to react to the speaker, not only because the content is really critical to what we're doing in medical education, but Clarence has been a sponsor for me. I was a medical student and a resident at a time, this will give away our ages, he was a junior faculty member, and I could see myself going to Robert Wood Johnson Clinical Scholars Program. I could see myself having an academic career by just sort of watching this guy out there do and be successful. So that's why some of this is important, is because you can't be what you can't see. And so it's really important for us to think about diversity from that aspect. So I want to say personally, thank you. And I personally know that he's been in rooms and spoken my name when I might not have been there. And so I think that that's important to know. I'm just going to give you a little bit of a feedback, because I agree with Sandra that I think having the community conversation is probably much more important than hearing me wax on. But I had some initial thoughts about what Dr. Braddock had sort of put forward. And what's interesting, I think, is there has not been a group meeting where people have sat down and said how to think about medical anti-racism and medical education. There has not been that conference. I have not been invited to it. But it's interesting that all of us start to talk about sort of the same structural barriers as well as similar approaches. And I'm going to give you a handful of potential ways to approach some of the things that Dr. Braddock talked about, and then we can open it for conversation. So one of the things is it's not just what's happening in medical education, saying the incidents that you talked about earlier necessarily about this idea about race being a biologic versus a social construct. It's in the nature of a presentation. So trying to change for decades, 52-year-old Black woman who presents with blah, blah. It is fundamental to how we take care of patients. And so I think we all have to change our language in that way. So Clarence, your thoughts about sort of thinking about not just the education enterprise, but the clinical delivery system that our students are embodied in.
Yeah, I think about that a lot, Monica, the presentation, and I really have two minds, and I think this is something we need. First of all, totally, when you said about there's been no national conference, it's kind of interesting because all these medical schools are standing up anti-racism this and anti-racist that, and even the AAMC has a massive presence in the president. So I just agreeing. With regard to the presentation, I used to think that it was inviting implicit bias and stereotype by saying 52-year-old Black woman, and I still think that. I also think that, back to this myth of colorblindness, that if our goal in the presentation is to understand the patient as person in service of really understanding their experience of disease and the social and other factors that are going to influence their health and their recovery from the condition, then we absolutely must know, and we must understand what it means that she's a Black woman, right? We must understand the data. We must understand her experience. What is her life experience, and not make assumptions. We make all kinds of assumptions, and I think that's the problem with just having it in the sort of chief complaint identity line. But if we can find a way to create a medical narrative that really unpacks the person's identity in ways that can help us see them as a person in service of their healing. I think that would be good.
So I'll give a shout out. Dr. Braddock has an article in Academic Medicine, I can't remember when, where he talks about rounding and talking about bringing those social issues to bear in everyday inpatient rounds in a study between Stanford and UCSF. So I think that is perfect. So we have a social history that might be the ideal place to create that narrative about the patient. The other thing that I have been thinking a little bit, I was drawn to your comparison between allyship, saviorship. And one of the things I've sort of been putting forth is this idea of what we need is co-conspirators. We actually need people to actually dismantle the system and help us and be willing to be put some skin in the game, not just stand by and say, we support you, but really sort of, how can we call on our allies to be more active in engaging around those structural competency issues?
Yeah, the first thing to say about the allyship sponsorship, and I'll give very briefly just an example of what something that happened last year. One of our residents was rounding with the attending, a Black woman resident rounding with a white male attending, and a patient made some overtly racist comment. The attending says, well, gosh, that's really not good of you to talk to my colleague that way. Invites the colleague to leave the room so that he can complete and so you can imagine looking at through the lens of, is that allyship or saviorship? And to cut to the chase, and when we were debriefing with the resident, what she said was she was grateful that he had said something, but she left still with a sense of harm, and that harm had not been addressed. And she gave the example that if someone had been, struck by a patient, someone would ask, "Are you okay? Do you need to go to the emergency room to be evaluated? Or do you need to take some time off?" But it wasn't a physical, visible harm, but it was a deep harm nonetheless. And there were so there's a lot there for allies to learn. I do think that the key thing is, and I thought about this, that's why To Kill a Mockingbird popped in my mind, also because of the sequel, which I'm not going to say anything more about, but that this idea is that if the ally is doing the act so they can feel better about themselves, they really need to think about their motivation. And the second barometer would be, is the person that you're trying to be an ally for more empowered or change in a positive way after your action, or are they pretty much still in the same lack of agency, oppressed? And if it's the latter, you really haven't been an ally. You've been a savior.
I think those are important points, and we have colleagues here, Jean Marie Bradford, who's working on upstandership and really sort of this idea of addressing the harm in the acute setting. So thank you for that example. Another thing that you've taught me over my career is this idea about asset-based approach to taking care of patients. Sean Harper has done a lot of work looking at the anti-deficit approach, particularly among getting more Black men into college. So I recommend his work if you're interested in it. It's several national studies looking at reframing a lot of the problems we see or what we might see as problems as learners, more diverse learners navigate medicine and the medical education continuum. How might we think about an asset-based approach, or definitely using an anti-deficit approach to address issues as we think about learners and their experiences?
Well, great question. I would first start by just calling out and acknowledging that I have so much admiration for your work in this area. That makes me a little bit hesitant to speak with anything other than commentary. But I think that it's interesting as you look at medical schools that do, at least numerically, reasonably well on diversity, and then you kind of go inside and you talk to the students. And certainly in our institution, not to talk out of school, but our institution, we do pretty well by by the numbers, compared to other medical schools. But within the medical school, we do still have issues of identity and a very deficit-based approach. And this sort of stereotype threat, which is a concept I really didn't know about until probably 3 or 4 years ago, that how we talk about and communicate to the Black medical student, the Black male medical student, has an impact, right? If it's a deficit-based, what can we do to help you? Maybe like a tutor, maybe the student wants a tutor, but how we approach that can actually impair performance. I remember a student from several years back who had sailed through with just off the charts record as an undergrad, but struggled. And one of the struggles was that this student had attended an HBCU and had been in an environment that there was not a deficit-based approach. There was a community. And so I think one of the challenges is how to create that kind of community and an asset-based approach in schools that aren't HBCUs. And, there's been a lot of talk about should we have more HBCUs? And, I have sort of honestly mixed feelings about that, because I have not experienced that in my career, but I have friends and family who have, and it sounds like a phenomenal thing. But that's it. So yeah, it probably would be good to have more HBCUs, and it probably also would be good to replace the deficit-based approach. Oh, look, we have, look how many Black medical students we have. Aren't we great? Replace that with, how do we actually create an asset-based approach that that transcends inclusion to actually sponsor the success of those students, rather than say, do you need a tutor?
Yeah, I agree with the conflict. And one of the interesting things I think you actually just brought up is it's the and, because if we took an asset-based approach of the historically Black colleges and universities, along with the Hispanic serving institutions and the tribal institutions, what can we learn from them in our predominantly white institutions? Because they obviously have some skill set that we probably can borrow. And we often think about knowledge transfer in the other direction, but I think for many of us at the typical R1 institutions might actually think, what can we learn from them about creating community and association? So I agree with that. And then I guess you hinted at this a little bit at the end, and I'm going to invite the audience to respond a little bit after you do, this idea about faculty. So I think many of the concepts that we've talked about today, quite frankly, our learners are, they got it. Like, in fact, they might be the master. They're the master class. Mm-hmm. It's in fact the faculty and the educators and the clinicians and the scientists that need more help in this area. And I guess, how have you thought about that from your perspective of either as an educational and a medical school leader, how to address that, or how might we approach that issue?
Yeah, it's a good question. As you were thinking about the prior questions, I will look forward to hearing what people say. I do completely agree that our learners are first of all, many of them have a lot of these concepts are being taught in their undergraduate training. We're of course being much more broad in medical school admissions and really inviting and embracing folks who have a degree in political science or art history or whatever. And so I think that the breadth of exposure, and also just living in a world in which there's much more active discussion of these things. I think that a lot of the concepts that are embedded in the mental models of faculty are really probably the biggest area for change. I've frankly been a little disappointed in kind of the knowledge-based approach to changing that, teaching faculty about implicit bias, teaching them about in-group favoritism. There are people who will have an epiphany or some insight, but then revert. We actually had at UCLA, we had a program a couple of years ago where we had sessions like that with breakout groups. And the breakout groups were 5 or 6 people, and the breakout always was designed to be diverse. So there's always at least one Black or brown or Native American or Asian or someone from a minoritized group. And more often than not, what happened in those groups was that the white participants would turn to the person of color and sort of look to them for answers. Or they would say, I never realized this, or I never realized that, and not recognize the trauma. So that just tells you that there's probably a spectrum in terms of receptivity. But I think the one thing, if I had to choose from, among the many things I said and many others, that it sits foregrounded in my thinking right now is a sponsorship versus mentorship. And as I watch faculty, research faculty who are bringing students into their lab are just, it's like in-group favoritism on steroids. And that's a natural, again, these aren't intended to be pejorative terms. These are just reflecting what's happening in our brains. And we have to be aware of that and actively. So, we are always looking for proteges who are, miniature versions of ourselves. And that means that white male students will have a white male faculty member who will take them under their wing, get them on the best papers, et cetera, et cetera. And the Black woman medical student might have a faculty member who takes them into their lab, but it's thinking about them in a completely different way. So if I could wave a magic wand and change that.
Well, I'm always grateful to have some time with you. This has been a delight for me, and I hope others have been as rich as I have. And thank you for bringing your perspective to Vagelos College of Physicians and Surgeons, because I think it's really important to hear this. And I think Sandra's going to let us open this up more broad to the community. And there's a couple of questions in the chat box to continue this piece.
Yeah, there's been some great questions, and thank you to both of you. It's wonderful to hear you in conversation with each other, and we're going to continue that. I do want to encourage folks to submit your questions, and we will get to as many as we can. And there has been some upvoting. I want to recognize the first question that came in actually was from Jim Tabery, and he asks, can you talk a bit more about the role that medical students can play in these anti-racism efforts? And he notes that there is this balance between, wanting to act, but also feeling like the burden is all on them, the next generation, to kind of fix these issues. And if both of you could comment on that, that would be fantastic.
You want to go first, or should I?
So here I had a coffee, just a fortuitous, before we got on, I had a coffee with a couple of our fourth years, because I realized, oh my God, they're leaving. And I actually asked that question. And it was interesting because one of the answers I got was similar to Jim's thought, that we needed to create, the student told me, some of the issues. We've created an equity and justice program. We have invited the students, but we still don't have enough structure to invite in a real way. And I think this idea of you're not just an add-on, that you're really intrinsic to what we do and we value you. I think here, I have a lot of work with that. Here, I'll make an I statement. I personally need to work on how to keep medical students involved without, going to them and saying, hey, what about this? I mean, their role is to get a degree. In our case, sometimes multiple degrees. So they are busy, but this idea of how can I invite a consultative role? And I think that was my take-home lesson this morning from our students here at VPNS, was using them as consultants, just like we do at the hospital, right? We don't expect the consultants to take care of our patient. We don't expect the medical students to take care of the curriculum. Maybe we should expect their expert opinion to weigh in.
Yeah, I agree with that. In fact, as you were saying that, Monica, something that popped into my thinking was, the concept of community-based participatory research. And, in the same way, for people who are really steeped in that that model understand that it doesn't mean going to the community and saying, hey, you know, if we hold some free classes, will you enroll in our clinical trial? That's not, you know, it means that you're actually co-creating everything with. And I remember there was, I don't know who said this, but you know, it says it's not enough that you certainly shouldn't do things to people, and it's not enough to do things for people. You need to do things with people. And so, you know, I'm just thinking aloud here, translating that to this context. There's, you know, approaching it just as the way you said, as a partnership collaboration. You know, and we think about this in the patient encounter. I may be the expert on the biomedicine, but the patient is the expert on themselves. And so having that mental model. Now, what happened in our place is, you know, students who are interested and eager to do that in formalized ways begin to say, well, like you said, we're busy. You know, we don't want to be taken advantage of. And so we actually said that as they are working on these kinds of initiatives, that they should be paid. Sorry for putting that out there if you're not doing it already. But
they're in the fellowship program.
Exactly. Yeah. Okay. Yeah. Okay. I said that out loud, but no. But I think it's, you know, it's like if asking them to be involved, there's sort of different dimensions, and you know, I certainly have experiences, and I'm sure you have too, of where we're asked as you know, you as a Black woman, me as a Black man, to be on different search committees, and like the list goes on. And you know, we do it because we've each of us made a decision that it's better to add that burden onto additional work and be in the room where it happens than not. But each individual has to decide that. And I think that the problem is when people feel like either A, they're expected to without it being recognized or acknowledged in tangible ways, or B, where they're asked to do it for performative ways that aren't substantive. So I think that I agree with everything you said. I think, you know, we wound up having a group, and I didn't form it, so I take no credit for it. A group, they called themselves Students for Anti-Racist Curriculum, and they, you know, basically demanded a meeting every Friday afternoon with our curriculum dean, who, you know, to his great credit, he met with him every Friday afternoon for 2 hours, and the first, you know, several weeks were just basically everything that's wrong with every faculty member, every class, every whatever. But, you know, it was extraordinarily painful, but it was important. And so that group has been a very vital, you know, part of the, you know, at least this phase of the journey.
Great. Thank you. I want to ask or raise some questions submitted by Shamika Poetry Thomas, and she is underscoring, yes, you know, diversity, equity, and inclusion are important, but can we address how no amount of DEI can protect minoritized people? And she is raising the events in Buffalo and the victims that were killed by racism and xenophobia, and she's asking the question, which perhaps relates to the first question on you know, how medical students are impacted by having to provide care for families in the New York area. How do you address issues of racial trauma and wellness? There's a lot there to unpack, but I'd love for perhaps Clarence, if you could start, because you have in your presentation, you know, you kind of walk through the way in which DEI has evolved and developed as kind of the approach, and wondering if you could comment first, and then would love to hear from Feistine Lypson.
Yeah, just a couple of brief comments, because I also want to hear what Feistine Lypson has to say. So, but I'd say well, I think back to you doing, you know, a two or four or with. I mean, a lot of the DEI efforts were in the category of doing something for minoritized people in minoritized groups, and you know, it's well intended, and you know, I don't want to undermine the importance of things like, you know, holistic review for medical school admissions. You know, done well, it does attempt to really dismantle some of the tools of discrimination and lack of diversity. Yeah, so racial trauma has to be normalized as something that isn't a sign of weakness. Like, and I think I will just say many Black Americans of my generation, certainly my parents' generation, can fall victim to thinking that, like what's wrong with this generation? Well, we had to go through Selma and the wire hoses, or I had to go to a segregated school. I didn't have to go to a segregated school, but my parents did. So I do confess that it's a struggle for me. But I think I know part of my work is to recognize there's an intergenerational burden. Each generation experiences racial trauma that's what was experienced by the generation before and what they experienced. And so it's additive. There's always this thing like things are getting better, but it's actually additive. And so that was part of my own journey to try to get out of that mindset of thinking, well, you think it was bad now, back in my day kind of thing. The only other comment I'd make about Buffalo and whatever the next thing is I think for all of us, particularly the next D'Angelo book, by the way, I think it's entitled something like Why White Progressives Are Really the Biggest Problem. So I can't remember the exact title, but what she's talking about there, I haven't read the book yet, but just some excerpts, is that the well-intentioned white person wants to look at Buffalo and the perpetrator as a minority person who's a whack job, who can, thought of some different theories, and that's all it's in the media. And so fails to see how that individual is connected to them and connected to all of us. One of our recent areas of work at UCLA has been around students with disabilities. And I realized through that work that I had deep discriminatory prejudices about and was not receptive to the lived experience of a student with a disability. And I would say things like, well, we got you this, we got you script, we got you transcripts, we got this. Like, what more can we do? And I was failing to recognize my own bias. So I think that I'll stop there, but I could ramble for a long time, but won't.
So I appreciate that, and I wrote down the additive trauma point, because I think that actually is an important point for all of us to understand of this generation. And I went to an organizational leadership course, and all you can do is hear somebody's experience. You can't actually make a value judgment on that experience. So I do think it's really important to really hold those who are experiencing trauma and hear it, so that we can figure out how to address it. And I'll give you an example. In my role as vice dean, I'm kind of part of the system in some ways. And so when Buffalo happened, we had to make a response and make sure that the students were okay. I also held out for a couple of hours in responding to take care of myself, right? So there was also a piece of, as a member of the community that's effective, if the people who know, right, there's a piece of self-care that needs to happen. And I think one of the things about the wellness initiatives that are on many of our campuses, that are amongst many of our clinicians, is that perhaps we also need to actually push those wellness initiatives to be more inclusive, to really think about racialized trauma, because I think, in fact, it's different. Some of the things that Coke Columbia has been doing, and Tanya Richardson and Lou Baptista have been doing here, is allowing a space for faculty and staff to actually talk about that, I think is one way to address it. It also gets to the little bit of another question that's a little bit later, before we move on, is this idea of the reason why I think this moment is precious is because it actually is the moment where those who are historically minoritized no longer have to hold the torch for this issue. That's actually probably the most important message out of George Floyd's murder, is that actually if we leave it up to people who are already minoritized, nothing will change. we would have changed it by now.
Yeah.
That really we need all of the allies and co-conspirators involved in that conversation, and they need to hold a little piece of that burden.
Yeah, can I just add something? I know we were going to another question, but
No,
you talked about your experience of needing to make some kind of announcement. This was on the list of things that didn't make it to the top 5, but I wanted to just comment. So, a horrible, tragic killing like Buffalo happens. And so for those listening, what happens in the higher echelons of power is a lot of hand wringing. And the hand wringings of the following sort. Well, we got to say something. Well, what should we say? We got to do something to show our minority community that we noticed and that we care. Okay, well, let's write a statement. Well, we got to be careful. It just goes, it's like, it drives me absolutely crazy. I was about to use the B word there, but I left that out, but it drives me absolutely crazy. And, I've been, through this more times than I can count. But as I zoom out from that, from my own frustration, what I realize is that is white supremacy in action. And white supremacy and white racial framing says something happened that the Black and brown and minoritized people are going to be upset about. We need to say something to make them feel better. We need to tell them about all the resources that we have for them to make them feel better, because their trauma is pathology, and we want to treat that pathology and feel good about ourselves. Now, that may sound overly harsh, but I'm just deconstructing it. So to the students, if your institution, and I know what my students would say, if your institution fails to address in a way that seems to be about what they are experiencing, what you want to hear is if I'm the chancellor or the president or the dean or the vice dean or whatever, what are you experiencing? I know what I was experiencing. I was happy in those town halls to tell students what they thought of it. I don't know, but unless it appears authentic about and not performative, like, okay, they put out a statement, yay, but it's a real problem. And every time there's a trauma, that we had, the anti-Asian hatred and violence, and numerous things around our Native communities in California. So every time one of those things happens, there's the hand wringing, which is the hand wringing of white racial framing. And the reason for the statement is not to actually say something, is to say something so that the people will stop complaining. Sorry for the rant.
No, that's super helpful, and I'm glad we're getting into this conversation. Actually, Hetty Cunningham has a question that I think will push us a little bit. So she's asking, how can we support our majority colleagues to join in this effort? Some of them are worried about doing or saying the wrong thing. Her question is, how do you build momentum with as many members of our community as possible? So if we're thinking about just your last remarks, what should our majority colleagues be doing?
Well, first thing I would say, now I'm just gonna make one comment and then I'll let Monica talk. Read D'Angelo's book. Do that this week.
Yeah.
And then we'll talk.
I think it'd be uncomfortable. So I sit in meetings, and my biggest advice is it's actually okay to be uncomfortable. My internal conversation is, because I'm uncomfortable every day, but so I know it's okay, right? So I know from personal experience it's okay to be uncomfortable, but I do think that inviting the uncomfortable feeling is important, and I also think we need to support them, right? So I think that's the other the piece of it, and allow room for the dissent, which I hope is curious, right? I'm okay with curiosity. Judgment becomes a problem, and so I think that's that would be the best for it. And quite frankly, all of us aren't safe, right? If we don't do this, we're all now victims of sort of this ongoing, either real life violence or symbolic violence in a real way. So I think I can't say that that's worked. We were sitting in a pandemic necessarily where we thought that maybe the thought about the social well-being would put people primary, but I also think there's some selfishness that you can actually use, because I don't think you want to operate in these systems either.
Yeah, those are fantastic comments, way more insightful than what I had to say. But I would just add to the uncomfortableness. In fact, I would say that to my majority colleagues, as you're trying to do this work of being engaged, if you're not uncomfortable, you're probably not doing enough. And also to amplify the last point about seeing the connections between, if it helps to see the connections between being engaged in this work for you as a person of white privilege. Another great book, it's actually going to be our common book this coming year, is Some of Us by Heather McGhee. Mm-hmm. Heather McGhee is a well-known, I think I can't remember her background, she's a journalist, I want to say. But it's basically, her thesis is trying to understand racism, not just as something that victimizes oppressed, minoritized populations, but it affects all of us. And it's an outstanding book.
Great. Dr. Amiel, thanks you both for your talks, and asks if you could share suggestions for best practices in training faculty to be anti-racist educators. You've talked a bit about that, but if you could expand on what you would advise in terms of training for faculty.
Well, I can tell you what doesn't work, and then I do have some thoughts. I think all of our institutions that are launching anti-racism efforts are launching training efforts. They take the various forms or videos to teach people what is implicit bias, and using actually some outstanding content. There are surveys, and there's small group discussions to reflect on experience or listen to my individuals from minoritized groups talk about their own experience and be moved by that. And that allows you to say, we've done X number of hours and this and that of that, and it has very little impact. I think that the thought that I have is, and this comes from just anecdotal experience with faculty, with particularly white male faculty that I've had this kind of conversation with, where they sometimes it's something that they've done or said that's egregious, and they're kind of a little bit on the ropes organizationally, and hence receptive to some conversation. But sometimes it's people who, I think of one colleague who, we were at a meeting and some comment was made. It was actually a meeting about something unrelated to all this, but related in a very central way, which is our health system payer mix. And what, how are we doing serving the Medi-Cal and uninsured population of Los Angeles? And, newsflash, not very well. And the colleague chatted something to me. He said, this seems to me like it might be racism. And I said, well, you should say that. He said, well, I don't want to I said, no, please, you should say that. So he said it. And so he had a thought, he made a connection, and was trying to get the agency and self-efficacy to actually engage. So him saying that, as I think about our payer mix, I'm worried about how it's, an example of institutional racism for the community of Los Angeles. Coming from a white male, that's going to be heard in a much different way than if it comes from me, because I say that all the time. So it's just that's an example that stands out to me, and I just from my own experience.
I've been thinking a lot about this with our Center for Teaching and Learning, and they've taught me. I actually don't think we can teach anti-racism, because you actually have to be self-reflect. You have to be in a place of self-reflection to be engaged in anti-racist behaviors, actions, etc. What we can mandate from an educational point of view is inclusive teaching strategies. Those inclusive teaching strategies are actually structures. So one structure is, there's a long history of intergroup relations, really built on establishing how to talk about conflict. These groups really started out of the conflict in the Middle East. And those tools of holding making sure everybody's heard, holding a space for dissent, not making people be represented. There's some actual skills, pedagogical skills that one can use to facilitate discussion. I think that's what we can hold people to account for. We can hold people to account around structures. And I'm learning more about that as well. And I think that's something we can demand of our faculty. The anti-racism point, to Clarence's point, is a different piece. And I do think we need to sort of think a little bit about what our expectations are.
One tiny thing I would add, I really like that comment about the last point about conversation, dialogue. One thing I talked to someone who'd gone to a training program in Florida. I can't think of the name of it right now, but this is a white colleague who was going to be a train-the-trainer program to bring back an anti-racist pedagogy training to our campus teaching and learning center. And when she arrived at this training, they divided the small groups by race. So they had the white trainees, train-the-trainer trainees in one group, and the black and brown and other underrepresented minorities or people of color in another group. And the conversations were very different. So the conversations among the white group was to try to unpack their own white racial framing and having them understand and talk as white people about that. And for the other group, for the black and brown and Native and Indigenous and Asian and et cetera, was to talk about their lived experience. So as they were going to train others about anti-racist pedagogy, they also had to first do their own work. And that seemed to be like a really, really good move. And of course, at the surface, I brought that up at our institution. People thought I was like, I don't know what they thought, but you seen through that lens, it's actually was a very powerful thing.
Great. So I'm going to switch gears a little bit, and there's a question here about sponsorship versus mentorship. And Lauren Manning, noted that Dr. Lypson, you said, you can't be what you can't see. Clarence, you spoke about the benefits of sponsorship versus mentorship. She asks, what steps, if any, have been taken toward a mandated asset-based sponsorship programming approach? Very specific question. And I guess, I would add to that question, because of your experience assessing progress, Clarence, like what has worked? How do we know we're moving the needle in applying these different approaches?
Yeah, well, I have a lot of ambivalence about this, because a lot of the efforts that I've seen, I'd love to hear what Monica's experience, and certainly for the lens of her work in assessment. So our institution, for example, we have we just are launching a program called the Justice. Well, basically, it's called the acronym is JAM. That's not important what it stands for, but basically a cadre of senior faculty of color who will be brought into the dean's office as a cadre of mentors/sponsors. What a fabulous idea, right? To both acknowledge that the mentorship sponsorship, they acknowledges you can't see what you can't be what you can't see. It's fabulous. But I also have mixed feelings, because it's basically saying the only people who can do that work for people of color are people of color. And then you get into the minority taxes. And the answer is, okay, well, no, we're going to take care of the minority tax. We're going to pay people to do this. But it still begs the larger question. Why do those JAM mentors have to all be people of color? And I know the reason, but yet the reason is part of the problem. So I think that I haven't seen, honestly, any models at work. I haven't extensively looked at this, probably the same way that Monica has, and certainly haven't looked much outside of medicine. My daughter's in the business world, and she actually was a quote that you may have noticed. Was my daughter, who's written a number of pieces about what corporate world needs to do to advance in this space. And a lot of those lessons are just as relevant here as they are there. So, but yeah, Monica, what's been your view on this?
So I think Lauren's question is fascinating. It's making me think, because quite frankly, I don't think sponsorship is programmable. Like, I haven't actually thought about sponsorship as a structure.
Mm-hmm.
And the reason I haven't thought about sponsorship as a structure is because the true definition of sponsorship, and this comes from my work in the intersectional world of really thinking about women in academic medicine, is you have a sponsor is somebody who so imagine we're, the three of us are having a committee meeting, and I say to Clarence, Hetty's not on this call. I'll use her because she'll beat me up later. Hetty, Clarence, if you need a speaker to come and talk to your folks about the Equity and Justice Fellowship Program and how to structure it, you should call Hetty Cunningham. That's sponsorship, right? That I put something on the line. So if you think about what I did was I put my personal reputation on the line because I have given him a recommendation. Hetty may or may not know about it. If he invites Hetty, hopefully Hetty will perform. Hopefully Hetty will perform. So I actually have skin in the game as a sponsor because I'm vouching for the person. So I guess and I think that is why the example, Clarence, you gave about the lab, that implicit comment we used to talk about, that's what happened on the golf course, that, and if that's what happened, that it really wasn't some structure that was happening. It was just really this idea that I'm willing to put some skin in the game to sort of say, if you need an ethicist, call Sandra Lee. Like, that puts me and my reputation on stake. So I will think about this because I do think it is an impressive, like, can you teach that? Mm. Or can you, yes, I can teach the skill, but can I guarantee that it happens in the real world? I don't know. And I think that's the thing about the assessing this mentorship programs overall, are, they're not harmful typically. And they might do slightly some good, but this is not a winning intervention by any means because of all of the things we've talked about on this call. Those relationships are inherently biased, their power dynamics, there's all kinds of, eventually you're going to divorce your mentor, right? If you've been successful, eventually you don't need your mentor anymore. Like, they're fraught with all kinds of problems. So I don't know about a programming approach.
All right. We have possibly time for one or two more questions, but I did want to ask this important question from Qayyum Ahmed, who really points us to think about institutional responsibility and reaction. And he's asking the question or noting the fact that many of our medical education institutions, our institutions of higher learning, have a long legacy of racism and a tendency to glorify whiteness. In fact, our institutions are named, as he notes, after white men. Harvard just released its very in-depth report on their own institution's historical legacy of slavery and racism. How do we reckon with this? And what is our role as educators, as scholars, scientists? What is our role working in these institutions?
Yeah, it's a great question. What comes to mind immediately for me, thinking about UCLA, is the university sits on tribal land, as many institutions do, and those communities have had concerns, rightfully so, for many years. So university's solution was to agree to at every sort of, in fact, I didn't do it for my talk today. I probably should have. Well, we're not on UCLA campus, but anyway, but there's a statement that acknowledges the tribal land and thanks the nation for the use of the tribal land. So that seems like a very nice thing to acknowledge. It's acknowledging the history, but it's actually pretty insufficient, right? Because if the University of California, if UCLA really wanted to reckon with and redeem itself for having taken and using tribal land, would merely saying, yeah, we took the tribal land and we're sorry, is that really kind of enough? And it really isn't. And it sort of challenges our imagination to say, what could UCLA do that would be beyond that? Would it be to invest in the community and the health of that community? That you could go on and you could have some imagination and some creativity around. If your goal is restitution, maybe even reparation, because you're not only just acknowledging you're going to repair, then you need to do something more than apologize. And I don't have this all figured out, but one of the things they've come across in this work is this this notion of restorative justice. And there are many experts. I'm not an expert, but the idea of having dialogue where the goal is to not just have someone apologize. You took your land. Sorry about that. Well, we got it now. So what are we going to do? We'll just keep apologizing every time we talk. It just, you realize when you say it that way, it's not sufficient. So I think something beyond that to really. I use the word reparation with great intent. It's kind of become a little bit of a lightning rod or flashpoint. But honestly, what is embedded in the notion of reparations is a real authentic repair of harm done. That an apology or an acknowledgement. We had the apology we've had public apologies from presidents for different things, and unless and until there's something beyond that, I don't think it's enough.
I don't have anything really meaningful to add. I think that those points are well taken. And I think we all individually, I think for the junior faculty, students and residents out here listening, I think those are things you want to think about when you think about an institution. I think that's all I can tell you. Those are things I thought about before coming, right? Like those are things I put in my consideration, and I think our institutions need to know that those are the things that people are considering when they sort of decide to join or not. But I think Dr. Braddock summed it up well.
Great. All right. Well, I think that's a great note to end on. I really want to extend my gratitude to both Vice Dean Braddock and Lypson for their thoughts today and their leadership on anti-racism. Really, the invitation to be uncomfortable. They've spoke very plainly and openly. And I'm really thankful that they have done so. I want to thank all of you for your participation in Ethics Grand Rounds and for engaging in this discussion. Our hope is that these conversations will support each of our own ongoing work in this area. Stay tuned for next year's Ethics Grand Rounds series. It will begin in the fall. Our theme will be incarceration, policing, and health justice. If you haven't done so, please sign up for our Ethics Division newsletter and you'll learn about these events and others that we sponsor. We look forward to seeing you again. And to the 2022 graduates who are in the room today, congratulations. We look forward to great work as you move forward. But please, everyone, take good care and thank you.
Thank you so much.